Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from ADV.
Hello, I'm Dr. Philip Meese, Director of Rheumatology Research at Providence Swedish Medical Center and Clinical Professor at the University of Washington in Seattle. Welcome to this program titled Breaking Boundaries, Exploring the Latest Advances in Lupus. Joining me today are Dr. Anka Askenazi, Chair of the Department of Medicine, Chief of the Division of Rheumatology, and attending rheumatologist at the Hospital for Special Surgery in New York, and Dr. Richard Fury, Chief in the Division of Rheumatology at Northwell Health, and the Marilyn and Barry Rubenstein Chair in Rheumatology, Professor of Medicine at Donald and Barbara Zucker School of Medicine at Hofstra Northwell in Hempstead. Welcome. Anka, what are some unmet needs we continue to have in the treatment of lupus?
I think that's a really big question. Let's see. Um, we still use things that we've learned somewhere, several decades ago. We use antimalarials, and they're wonderful and extraordinary medications that allow for disease control, flare reduction, and actually are associated with decreased mortality in lupus. We use traditional immunosuppressants, and over the past 15 years have now introduced biologics in the treatment of lupus. Um, we have we have learned how to use better belimumab, both in the treatment of extrarenal and for lupus nephritis. We have learned how to use anifrolumab. We have now learned how to use voclosporin, and most recently, we're learning how to use obinutuzumab. All of these medications are allowing for better disease control. Unfortunately, based on clinical trial data, they are imperfect tools to take care of people with lupus. We still have about 50% of the patients in all these clinical trials that um, don't have enough disease control. So, a lot more that we need to work there to improve these outcomes to where we're able to control 75%, 100% of people with lupus. So, lupus is challenging to treat. And beyond that, we still rely very heavily on the use of glucocorticoids. We're more aware that we need to minimize their use. We have learned how to be more parsimonious with their use from the start. The guidelines from both the European Rheumatology Association and the American College of Rheumatology are very precisely highlighting the goals of minimizing steroid use. But all in all, we're still using too much steroids. And part of that is because lupus is heterogeneous, both in terms of organ manifestations. It's heterogeneous in terms of severity. Um, and because our treatments are imperfect and disease activity continues sometimes unabated by our efforts, patients continue to accrue organ damage that has a profound impact on quality of life.
And especially difficult is the fact that we have imperfect ways of monitoring and assessing true disease activity, especially in the renal dimension where it can progress silently. So lack of really good outcome measures that get at the deeply into organ involvement is awkward and difficult and variably done across the world. Let's pause and hear from two patients, particularly about their story of living with lupus and some of the difficulties that this represents.
They decided to do some blood work to see why my knuckles were swollen. And the doctor called back and they told me that there was a rheumatoid factor in my blood work. And so I needed to go to the children's hospital. And after going to the children's hospital, they did tests, and lupus, as I'm sure you know, it can take a long time to diagnose because the symptoms can kind of be all over the place. My blood work was so sure and matter of fact that I was diagnosed like day one, put on medication, and then it's been 13 years now. We were devastated. So it was just like, it was good to be able to get all the answers and get the support from day one. And I had already been having little symptoms that we didn't realize were lupus. So that helped to be able to automatically get some medication and things to kind of stop those things in their tracks. I don't feel like I got a full understanding of what lupus was from day one. I feel like it was just you have lupus. It's a autoimmune condition which can affect your organs, and we need to check all your organ function to see where your baseline is. At my worst, a day is I wake up in the morning or at whatever time I may wake up and I just literally head to toe just ache. And I'm tired. I feel like I can't I don't want to move. I don't want to think. I've had days where my clothes being on irritated me because I was just so achy and, the fatigue. I don't think a lot of people realize like, being tired is one thing and, you go to sleep, but literal, like in your bones, tired fatigue can truly be debilitating sometimes. And especially the days when, I still work. I work a full-time job. So even on some days where it's really hard to push through and I'm fatigued and tired, it really can take a big toll. But sometimes rest can help. But on those really bad days, sleep doesn't even. And that normally turns into a week or 2 weeks of just, being really tired and just trying to maintain. And normally a ER visit shows up during those times. And that's when I know, like when I feel like I need to go to the emergency room because I need something that I don't have at home. So you definitely get frustrated. It gets frustrating every single day having to take medication. And then as more things come on, you get new medications. So I take 7 medications a day right now. A couple months ago, I had some blood work done and they saw more protein in my urine than what they would like to see. So then that automatically gives concern for kidney issues. So they feel, okay, the hydroxychloroquine has been doing great. However, it's not enough anymore. Let's put you on what's called a biologic. So I'm like, what? So they explained to me that it's going to be an infusion and, it'll run for an hour and it is solely the purpose. The goal long term, of course, is it to help with pain and for it to help with my fatigue. But the major concern is more protection for my organs. I'm experiencing more things as I'm getting older and my body is getting older. And so every new thing is like, okay, here's something else. Or if I add a new pill or if I add it can affect your mental health. I have a 3-year-old and just to think this is her whole life, I'm dealing with this. And I don't know what my health is going to look like in 10 years. I don't know what my health is going to look like. So a lot of times I think about how my health conditions are going to affect her. Even now, there's times when I'm not feeling well and she wants to play, or I'm in pain and she's crawling all over me and she has no idea, what's going. She knows mommy takes medicine, and she knows, certain mommy has to go to the doctor and things, but we have a long journey of me trying to be the best mom that I can be for her while dealing with this condition.
I went to a rheumatologist, and the first rheumatologist told me I was crazy and that I was depressed and that I was working too much. So I found another doctor that actually sat down and listened to me and reran the test. And I came back in for a follow-up, and she said, I just want to let you know that you have lupus, and I'm here to provide whatever resources you need. I actually came home, did a lot of research. I'm familiar with the word lupus. But again, when you are experiencing it and reading it is two separate things. Or knowing someone that has it and then you experiencing yourself is totally different. So I came back and I kind of wrote down questions that I had. Again, you go on Google, you find everything. You're like dying tomorrow. So when I was first diagnosed, I was put on steroids. And actually, I think at that time, because my flare up was so huge at that time, I was in a lot of pain. I believe I started at about 30 milligrams once a day. I also got started on hydrochloroquine. Obviously, I was familiar with steroids, and I was familiar with the side effects. So here comes the gaining weight, the extra energy, the wanting to eat everything sweet, and the insomnia that comes along with it. So, and I got every one of those side effects. I take 27 pills a day currently. I also do 2 injections, which is a biologic. I also do a infusion for migraines. I also get injections in my esophagus and in my scalp and head every 6 months for different things. But my medications have increased through the years. With you take one thing for this thing and then you get a side effect or it's not working, so let's add this one more thing to it. So it's kind of a cycle. I set them up every week. So I'm not picking up 25 pill boxes or containers every day. Some people choose to do that. I'm very organized. I have a bit of OCD. So for me, it makes it a lot easier to just organize all the pills at one time, once a week or every 10 days. Because if I had to pick up pill bottles every day, that would be my full-time job, like picking up pill bottles all day. So, and then I'm very organized with the calendars. So I put the injections and the biologics and stuff like that in my calendar, so I am right on. People don't understand with lupus, you hurt every single day of your life. And the more things that you have wrong, so I have multiple autoimmune diseases. Lupus has taken control over, I have lupus nephritis. I just recently got diagnosed with a heart condition from lupus. I also have gastro issues like gastroparesis, esophageal spasms. I have really bad acid reflux. It has attacked my eyes. I have what's called scleritis. Obviously, you have knee and joint and muscle involvement. So to name, I have a platelet disorder. At one point, I just thought that they were just giving me medication. I come into the office, I have a complaint or something's going on. And they're like, here, try this medication, see if it works. I am very sensitive to medicine. You would not know that with me being on 27 pills. But it takes my body a long time to adjust. So I'm not the person that says like, yay, yippee, I'm taking another pill. No, I do my research. I look it up. And if I feel like it's not working for me, I will let my doctors know that this is not working for me. This is making me too sick, too tired. It's been 3 weeks. My body still hasn't adjusted to it. And we have a conversation about it. And sometimes they say, well, try it a little longer. Just give it another week or two. Or they say, all right, stop it. Let's try something else. So every week I take out medications. And every week I get angry. Because I'm sitting usually on my bed, and I am putting 27 pills for one day, for 7 days, sometimes 10 days. And I get upset every single time I sit there. But then I come back to realize that these medicines are actually keeping me alive, keeping me healthy, giving me some quality of life. People go, how are you still smiling? How are you still getting through your days? And my answer to that is, but God. Because literally every day I ask God to give me some type of relief just to get through that day. Not tomorrow, just today. And I smile.
As we have just heard, there are a number of negative health and functional impacts of SLE, and there continue to be limited effective therapeutic options. To fill this need, there are a number of new targets being studied. Before we review some of the most recent data on emerging therapies, let's look at an animation that will illustrate the mechanism of action of some novel therapies.
The evolving therapeutic landscape is now marked by an array of novel agents, each developed to interfere precisely with key pathways central to lupus pathogenesis. Let's review these novel agents, grouped by their targets and mechanisms. Disruption of the JAK-STAT signaling axis has emerged as a promising approach, given its role in signal transduction of multiple inflammatory cytokines. Upadacitinib is a small molecule, selective Janus kinase inhibitor that disrupts signaling pathways implicated in lupus, such as type 1 and type 2 interferons, T cell activation, and several interleukins. Deucravacitinib selectively inhibits tyrosine kinase 2 or TYK2, specifically modulating pathways driven by interleukin 10, IL-12, IL-23, and type 1 interferons, key contributors to inflammation in lupus. Now let's look at some other emerging targets. Obinutuzumab is a glycoengineered type 2 anti-CD20 monoclonal antibody that targets CD20 and induces potent direct cell death, antibody-dependent cellular cytotoxicity, and phagocytosis. Ianalumab targets the BAFF receptor, resulting in B-cell depletion via antibody-dependent cellular cytotoxicity. In addition, by blocking the BAFF receptor, it also inhibits the BAFF pathway, hence it has a dual mode of action. Dapirolizumab pegol is a pegylated anti-CD40 ligand antibody fragment that blocks CD40 ligand interactions and thereby attenuates key co-stimulatory signals required for immune cell activation. Litifilimab, a non-cytolytic IgG1 monoclonal antibody that targets BDCA2 on plasmacytoid dendritic cells, blocks the synthesis of type 1 and type 3 interferons, cytokines, and chemokines. Enpatoran, afimatoran, and E6742 are small molecule inhibitors of toll-like receptors 7 and 8, critical in the recognition of nucleic acid containing immune complexes. Significant reductions in pro-inflammatory cytokines such as the type 1 interferons, as well as other pro-inflammatory cytokines, ensue. Nipocalimab, a monoclonal antibody that binds the neonatal Fc receptor, promotes the lysosomal degradation of IgG, thus accelerating the clearance of pathogenic autoantibodies as well as circulating immune complexes. Cenerimod is a selective sphingosine 1 phosphate receptor modulator, which restricts the egress of immune cells from lymphoid tissue into the circulation, thereby reducing peripheral lymphocyte counts and subsequent tissue infiltration. These novel targeted therapies are reshaping lupus management, further enhancing the outlook for our patients with systemic lupus.
Rich, could you tell us more about some of the latest data, starting with the JAK-STAT pathway?
Absolutely. So when we refer to inhibiting the JAK-STAT pathway, we're really referring to the inhibition of any of the three JAKs. So there's JAK1, 2, and 3, or TYK2, either alone or in combination. This pathway controls the synthesis of various cytokines, including interleukin 2, type 1, type 2 interferons, interleukin 12, IL-23, and interleukin 6. Now, upadacitinib is a selective JAK1 inhibitor. The upadacitinib phase 2 study had a very interesting design in that upadacitinib was tested alone, but also a combination with a BTK inhibitor, elsabrutinib. In fact, originally there were 5 treatment groups. In the end, upadacitinib 30 milligrams daily by itself was with an effect size of about 17 percentage points with the SRI-4 and prednisone taper as the endpoint at 24 weeks. The effect size at week 48 with LL-DOS was about 26 percentage points. Flare reduction was observed with upadacitinib, and there were no new safety signals. Upadacitinib is now being studied in phase 3.
And then, as part of the JAK family as well, there is the TYK2 inhibitor deucravacitinib, which has an inhibiting effect on a variety of cytokines, including IL-12, interferon gamma, IL-23. It's an oral selective tyrosine kinase 2 inhibitor that in this 48-week phase 2 trial assessed the efficacy and safety of this medicine in adults with active SLE. The groups in this study included deucravacitinib 3 milligrams twice daily, 6 milligrams twice daily, and 12 milligrams once daily, or placebo. And the results, the primary endpoint was the SLE Responder Index 4 response at week 32, and the percentage of patients achieving the primary endpoint were 34% with placebo, 58% with deucravacitinib 3 milligrams twice daily, 50% with 6 milligrams twice daily, and 45% with 12 milligrams once daily. So response rates were higher with deucravacitinib for BICLA, Class C50, LL-DOS, and joint counts compared to placebo. The rates of adverse events were similar across the groups. Higher rates of infection and cutaneous events, including rash and acne, were seen with deucravacitinib, which is a known side effect of this medication. So these are promising results, and it looks as though this will hopefully be an addition to our armamentarium, depending on further results of this drug in lupus. Anka, we've seen that B-cell depletion has shown benefits in lupus. Can you tell us more about inalumab?
Ianalumab is a monoclonal antibody that targets the BAFF receptor. It both depletes B cells, but also decreases BAFF. So it's an interesting dual mechanism of action. The data from the phase 2 trial were promising, and a phase 3 is currently ongoing in people with lupus. As now is customary, the primary outcome was a composite outcome, the SRI-4. Because the drug has a very rapid onset of efficacy, the SRI-4 was evaluated at week 28. And after week 28, patients were allowed from the placebo group to cross over in the treatment group. So a little bit of an interesting design here for this phase 2 trial. And for patients that were treated with the most effective dose, which was 300 milligram of ianalumab, 44% of them achieved SRI-4 and corticosteroid reduction, as opposed to only 9% in the placebo arm. Additionally, other outcomes were evaluated at week 28, significant reduction in SRI-6, so a decrease of the SLE disease activity index by 6 points, achievement of remission, achievement of low disease activity, flare reduction, decrease in corticosteroid use. Ianalumab was not associated with an increased risk of serious adverse events or serious infections. Some injection site reactions occurred, but overall, this was a well-tolerated drug that is now being evaluated in phase 3.
Thank you very much. Rich, you were a lead investigator for obinutuzumab study. Can you tell us about the findings from this study?
Sure. So, on the topic of B cell depletion, obinutuzumab is a potent B cell depleting antibody targeting CD20. Now, you could call this granddaughter or grandson of rituximab, but it differs in several ways from rituximab. This molecule was defucosylated, which basically reduces the steric hindrance in binding with the Fc receptor. And so the end result of this is that there's greater antibody dependent cellular cytotoxicity and also greater antibody dependent cellular phagocytosis. In addition, because of a type 2 binding configuration, there's greater direct cell death. It was first put to the test in lupus nephritis, and both the phase 2 and the phase 3 studies, known as Nobility and Regency, were successful. And these results led to the FDA approval of obinutuzumab by the FDA for lupus nephritis in the fall of 2025. So next on the agenda was to study SLE, and it was studied in the Allegory trial. Approximately 300 patients with active SLE were enrolled. The endpoint was at 1 year and consisted of the SRI. We observed robust results with an SRI response at 1 year of 77%. The effect size was 23 percentage points. All 5 key secondary endpoints were successful. These included the BICLA response, steroid reduction to less than or equal to 7.5 milligrams per day for the last 12 weeks of the study, sustained SRI response, SRI 6 representing a higher threshold of response, and the last one was time to bilive flare. We did see infections and neutropenia. They were a bit more common in those who received obinutuzumab, but quite manageable.
Thanks very much, Rich. Next, we have dapirolizumab pegol, an anti-CD40 ligand antibody that is involved in co-stimulation blockade. This is a phase 3 study to assess efficacy and safety in patients with active SLE, 48-week trial, 321 patients. And the groups included patients that were treated with dapirolizumab pegol 24 milligrams per kilogram or placebo every 4 weeks in addition to standard of care. The results, primary endpoint of BICLA response at week 48 in the dapirolizumab pegol group, 50%, and in the placebo group, 35%, so for an effect size of 15%. And in terms of safety, treatment emergent adverse events occurred in 83% of patients receiving study drug and 75% receiving placebo. We also have a few emerging therapies involved in interferon inhibition. Aka, what do we know about enpatoran?
Enpatoran is an oral small molecule inhibitor of the toll-like receptor 7 and 8 that downstream decreases interferon and interferon signature. This was studied in a phase 2 trial of moderate to severe people with lupus. Several doses of enpatoran, 25, 50, and 100 milligrams BID, were evaluated compared to placebo. And unfortunately, in the study, the BICLA response was not met. However, there were meaningful benefits across pre-specified secondary and exploratory clinical and biomarker outcomes. Safety was good. The drug was well tolerated. So further development is planned. So another TLR7/8 antagonist, E6742, is currently in phase 1-2 trials. And so far seems like it has a favorable safety profile and shows good suppression of the interferon gene signature responses as well as preliminary efficacy signals.
Rich, what do we know about litifilimab?
It's a very interesting monoclonal antibody that binds a protein called blood cell dendritic antigen. It's easier to just say BDCA2. And this protein is believed to be exclusively expressed on plasmacytoid dendritic cells, which are mass producers of type 1 interferons, but they also make other cytokines. And when BDCA2 is ligated, it is internalized. And synthesis of not only type 1 interferons, but type 3 interferons, as well as other cytokines like TNF and interleukin 6, are shut down. So the antibody is not cytolytic, it just seems to put the PDC to sleep. So, based upon the results of the phase 1 study, the program advanced to phase 2, which had two parts. The overall program was called Lilac, and one part called Lilac A studied patients with active arthritis and rash. And there we observed a statistically significant reduction in active joint counts. And more importantly, we saw a 27 percentage point SRI effect size. Although herpes infections were seen in the Widifilimab group in Lilac A, there were similar numbers in the placebo arm as well. And based upon the phase 2 results, this program has advanced to phase 3 studies of both systemic lupus and cutaneous.
We also have a selective sphingosine 1 phosphate receptor modulator in the pipeline, cenerimod. Anka, you were a lead investigator in the phase 2 trial. Can you tell us about some of the findings?
So, sphingosine 1 phosphate modulators are approved for the treatment of IBD and multiple sclerosis. So, attempting to use them in systemic lupus makes a lot of sense. This receptor is involved in lymphocyte trafficking, both egress of lymphocytes from the lymph node and into the tissue. So, less inflammatory lymphocytes in the tissues and sequestration of lymphocytes in the lymph nodes. The phase 2 study was called a CARE study. It looked at the efficacy, safety, and tolerability of 4 doses of cenerimod in people with lupus. The dose that advanced to phase 3 is the 4 milligram per day dose. And that particular dose achieved a decrease in SLEDAI scores at 6 months that were with a p-value of less than 0.05 in the study, but when adjusted for multiplicity, that lost statistical significance. Cenerimod was well tolerated. 2 phase 3 studies are currently ongoing and will give us better understanding of the efficacy and safety of this drug.
Thank you very much. Rich, we have a neonatal FC receptor antagonist, nipocalimab. Results recently presented at EULAR in 2026. Can you walk us through the findings?
So the study was known as Jasmine and the antibody nipocalimab. And it's interesting biology that kind of speaks to the efficiency of our bodies, of the human body. So basically, this antibody, which was given during the study every 2 weeks intravenously, binds the neonatal FC receptor. And in doing so, it prevents the recycling of IgG without any effects on other isotypes. So without interfering with the this FC receptor, the body basically recycles IgG as well as albumin. Interrupting this cycle means degradation not only of IgG, and it could be good IgG and it could be pathogenic IgG. There's also degradation of circulating immune complexes. So going back to the study, the comparison was between placebo and then 2 different doses of the nipocalimab. And I'm just going to speak to the higher of the 2 doses because that's where we saw an effect. So the overall effect size between the higher of the 2 doses of nipocalimab, namely 15 milligrams per kilogram, and placebo, was just a modest 14 percentage points at week 52. But we did subgroup analyses, and there were 3 subgroups that yielded some interesting results. Patients who were classified as being autoantibody positive, because of a certain autoantibody profile, had an effect size of 22 percentage points. Then the second group, which was a very small group, was characterized by a high interferon signature, circulating immune complexes, and a low C3. The effect size here was 65 percentage points, but again, the total number in this group was small. But the third group consisted of interferon high patients, and the effect size here was 24 percentage points.
That what you just mentioned also suggests that maybe we should be trying to um, figure out which of our patients have a certain biomarker phenotype that is going to have better results with some of these treatments, and so begs for improvements in biomarker science to characterize specific subgroups.
I fully agree with that statement.
As we all are aware of and taking part in research in, there are other approaches, including specific cell therapy or T cell engagers that are in development. For example, the CD19 autologous uh, programs, in which patients' T cells are engineered to express CD19 receptor and then are infused after a conditioning chemotherapy regimen and are quite effective in ablating pathogenic B cell populations. Uh, some of the data that we've seen, especially from Germany, suggests that this could be a one and done deal with a quote reset of the immune system. But we're also, as we see more and more data coming through, seeing patients having at least partial relapse. And so there's still important questions about how to uh, further put these patients into remission. Also, T cell engagers, which are um, uh, can be injected or infused and draw T cells together with pathogenic B cells in a patient and lead to the B cell ablation. So lots and lots of newer therapies that are in development from multiple companies that have developed cell therapies for treatment of cancer. We're now seeing them reach into the autoimmune disease world and treat a multitude of conditions: lupus nephritis, myositis, scleroderma, rheumatoid arthritis, and so forth, all of which have a significant B cell signature as part of their pathogenesis. So it's a very exciting time to be working with these newer therapies that uh, have the promise of getting us to a state of low disease activity or remission. So I'm curious about each of your perspectives on where these will all fit in the future.
I think that you started as Rich was talking about the data from the nipocalimab and the subgroup analysis. We started considering the possibility of um, better aligning what's driving lupus for a particular patient to the treatment. I do think that, especially as we more treatment options, we should be able to better figure out the correct drug for the correct patient. Now, lupus is never simple. In some patients, the disease involves the big cells and interferon, or the B cells and myeloid cells. So we might need to have, combination of treatments for people. I'm just wondering what are Rich's thoughts about this?
No, I mean, in a way, it's a good problem to have. We didn't have this problem prior to 2011. All these advanced therapies are recent. So we need to know which drug for which patient. And the SRI and the BICLA are regulatory endpoints. That's not what clinicians need to know. Clinicians want to know, how does it work in skin? How does it work in joints? How does it work in kidneys and so forth down the line? So we can certainly bucket our patients by clinical phenotypes, but I think we need to get more sophisticated and look at molecular phenotypes. Anyway, the future is here now, and this is being addressed.
I really like how you say the future is here now. It's quite an exciting time.
Absolutely agreed. Mark and Richard, thank you for this great discussion. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.